Our next speaker is Dr. Craig Coopersmith. He's the professor of surgery here at Emory, director of Emory's Critical Care Center. He'll be speaking to us today about the new definition for sepsis.
Thank you, and it's an honor to be here. So if you're following along on the slides in the book, I'll tell you that there's more slides in the book than the actual talk that I'm giving today. I wanted you to have the hour-long version, so you can see a bunch of things that I'm not going to have a chance to talk about, but you might find interesting. So starting with conflicts, my lab was funded by the NIH. It has nothing to do with what I'm going to talk about today. I'm the immediate past president of FCCM. I was a member of the new sepsis definitions task force. And the slides that I'm going to be presented today are a combination of three things. The first is the slides that were actually presented at the new definitions at FCCM this year. The second, we've done a couple of webinars in the last month or so for FCCM. And the third are some of my own slides and reordering. So I'm going to take this backwards in a way that I'm not used to doing, and I'm going to start with the conclusions of the new definitions because a lot of people are getting them confused, and I'm going to... Wow, I've got a bell going off. It can't be 20 minutes, is it? For them not feeling it. Okay, so the new definition. And while I have this up there, I'm going to talk about the definition of a definition, which sounds strange, and I'm going to get into this in the talk. Our current, everybody's used to what we used a couple of weeks ago, SIRS plus or a suspicion of infection, as the definition of infection is not actually what the dictionary would define as a definition. The definition is the essence of what something is. And what we've done historically is we've used clinical things at the bedside to define what something is. So the best way to think about this is a heart attack. If you have a heart attack, we actually can explain what a heart attack is. A heart attack is you're getting inadequate blood flow to your heart. You've got a plaque. You don't have an oxygen mismatch demand, and ultimately part of your heart dies. And you can see that by dead cells, by non-moving on the echo. That's the actual definition of a myocardial infarction. And at the bedside, what we say is you have an elevated troponin or an elevated CKMB. An elevated troponin is not the definition of a heart attack. The absence of blood flow and your heart dying is the absolute definition of a heart attack. So historically, we've used clinical criteria to define sepsis, but the new definition starts with an actual what sepsis is. So sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Again, we're going to start with all the conclusions from the Sepsis 3 paper. Organ dysfunction can be identified as acute change in the SOFA score greater than or equal to 2 consequent to infection. The baseline SOFA score can be assumed to be 0 in patients who are not known to have any previous organ dysfunction. And if you want to put this into clinical thing, a SOFA score greater than or equal to 2 carries an overall mortality of 10% in patients with suspected infection. Patients with suspected infection who are likely to have a prolonged ICU stay and die in the hospital can be promptly identified in the bedside, in the emergency room, and in the hospital wards, but not so much in the ICU, by something called qSOFA, which is an easy screen looking at just 3 things: altered mental status, systolic blood pressure of less than 100, respiratory rate of greater than 22. If you have 2 or 3 of these, your chances of having a bad outcome go markedly higher. Septic shock, again, we talked about the definition of sepsis being an intellectual construct. The intellectual construct of septic shock is that it is a subset of patients with sepsis in which there's underlying circulatory and cellular and metabolic abnormalities profound enough to substantially increase mortality. I'm going to give away baseline things before I get into the data. The new mortality for the new definition of sepsis is 10%. The new mortality for the new definition of septic shock is 42%, 4 times higher. And again, because we want to use something we can use at the bedside, septic shock can be identified by 2 things: a mean arterial pressure less than 65 and simultaneously a lactate of greater than 2. Key concepts from the sepsis definitions paper is sepsis-induced organ dysfunction can be occult. If you suspect somebody has infection, you should look for organ failure. Conversely, if you have somebody with organ failure, you should look for infection. And an important point is systemic infections may result in local organ dysfunction without generating a dysregulated systemic host response. So that's the conclusions before we actually start talking. It's called Sepsis 3 because it's the 3rd attempt at a sepsis definition. The first one came in 1991. The second one came in 2001. These are the papers you have up there. And basically, we haven't changed at all what we've used since 1991. So 25 years later, we're using the same definitions. If you're wondering how we came up with the original definitions, it was a bunch of guys sitting around the table and saying, I think this is what sepsis is. And that became the definition. And so everybody just says, oh, it is this, it is SIRS. And again, it wasn't evidence-based, it wasn't data-driven. It was a bunch of guys sitting around the table giving expert opinion. And we said, this is what it is. So what are some of the problems with it? Some of the problems with it is based upon the concept of SIRS. So I see Dr. Martin walking into the back of the room right now. If Dr. Martin had run into the room right now, he would have SIRS because he would have an elevated respiratory rate and an elevated heart rate. But he would not, in fact, be septic. We use the term severe sepsis. So originally in the definition you guys all know, there's sepsis, then severe sepsis, and septic shock. What's the problem with severe sepsis? The mortality, as I've just said, for sepsis is at least 10%, depends on what study you want to look at, 10%, 20%, 40%. That is higher than the mortality for a heart attack, higher than the mortality for stroke, higher than the mortality for trauma. By definition, sepsis is severe. By definition, sepsis is life-threatening. So having this combination, like some of it's severe and some of it's not severe, if it really kills more people than heart attack, strokes, or trauma, doesn't make a lot of sense. And there's different criteria leading to different results, which I'm going to show you in a couple of slides. So everybody loves the concept of SIRS. There's parts of SIRS that have tremendous face validity. When you're looking for infection that has tremendous face validity. If you look at somebody, they'll get a fever and a white count. That makes perfect sense to say that person might be infected. It doesn't tell you that person is more likely to die. It tells you that person is more likely to be infected. And so this is the top studies here is something done by Ronaldo Baloma, who was actually also on the Sepsis Definitions Task Force, published in the New England Journal of Medicine last year, showing that 1 in 8 patients who die of sepsis had 0 or 1 SIRS criteria. And whether you had 0 or 1 or 2 SIRS criteria, mortality was exactly the same. The bottom study over here is something that was published in the Blue Journal a year or two ago, showing that 50% of patients in the hospital wards have SIRS. And if we're in the ICU, basically 100% of our patients have SIRS. And so we're looking to screen for something that every single patient has. It's a little bit challenging to do so. And so the other problem is that SIRS is an appropriate response to an infection, right? So why do we have a response? We have a response in our body to try to fend something off. If we lose a whole bunch of blood in shock because we're getting a shot and we have a gunshot and we lose a bunch of blood, what's supposed to happen? We're supposed to have tachycardia because that preserves cardiac output. If you can't have tachycardia, what's going to happen? Your blood pressure is going to fall. So an elevated heart rate is an adaptive thing. Why do we have SIRS with an infection? Well, in the most simplistic way, our temperature goes up to go to a temperature that we can kill off the bacteria, but we can still live. Why does our white blood cell count go up? Our white blood cell goes up because we're trying to fight off the bacteria. More white blood cells trying to actually kill the bacteria. That's not a maladaptive thing. That's an adaptive thing. And the assumption that SIRS is a bad thing isn't necessarily true. It's actually potentially an adaptive thing. I said this before, different criteria, different results. And one of these studies is coming from Dr. Martin again at the back of the room. 4 different ways of benchmarking sepsis. Currently, if you use the 4 things that are published, the mortality from sepsis is anywhere between 230,000 and 370,000 Americans each year. And the number of people getting septic each year is somewhere between 870,000 and 3.1 million patients. That's ridiculous, right? 870,000 to 3.1 million, a 4-fold difference. So when we talk about the disease, if we actually can't say, if you say how many people get breast cancer this year, you're not saying it's going to be, 100,000, maybe 1 million. Those numbers are ridiculously different, but that's exactly what we have for sepsis, depending on how one wants to define it. I hit forward and nothing happened. Now it is. So I'm going to be talking about for the next 15 minutes or so is the Sepsis 3 document. This is it. It was published in JAMA a couple of weeks ago. So I'm going to start out with part of this was, in fact, a bunch of guys sitting around the table. And I will say it was a bunch of guys. It was 19 men, no women. That was a mistake. It was an error. And there's an apology coming forth. Not maybe as strongly as worded as it should be in JAMA. I will say strongly, from my standpoint, it was a mistake. It was an error. So it was 19 guys sitting around the table. 2 of us in the room right now are amongst them. Part of it is a bunch of us sitting around the table, and part of it is actually an evidence-based looking at databases of about 7 million patients. So we made a bunch of things, made a bunch of a priori decisions. First of all, we were not going to redefine what infection is. So when we look for infection, look for the same things you always are looking for. Fever, white count. You cannot define that somebody has infection until retrospectively if you get positive cultures. So and when we looked at the database analysis, how do we define infection if you're looking retrospectively? If somebody was concerned enough to A, send blood cultures, and B, start antibiotics and continue antibiotics for at least 3 days, that counted as infection, at least suspected infection. But we did not redefine suspected infection. We said sepsis is not simply infection plus 2 or more SIRS criteria for the things I previously said about SIRS. The host response is of key importance. You need an infection, but the fact that it kills you is how the body responds to the infection. If the body responds appropriately, you localize the infection, nothing bad happens, you're not going to die. If you get a bacteria, you try to respond to it, and then you respond to it, then you respond to it, and all the things go haywire and a bunch of organs failure, that's what's going to kill you. So the host response is of key importance. Sepsis represents bad infection, where bad equals infection leading to organ dysfunction. And finally, the term severe sepsis is not helpful because, as I said before, all sepsis is severe by definition. And so we got rid of the term severe sepsis. So those were things we decided up front. As I said before, a definition, if you actually look in the dictionary, is not clinical criteria. If you define something, it doesn't say, oh, you have this many white blood cell counts or something. That's what you're doing at the bedside. A definition is effectively the essence of what something is. So our previous definition was not the essence of what sepsis was. It was something that we can use as an easy screen at the bedside. So we wanted an essence of what sepsis is, understanding that our understanding of what sepsis is incomplete, but we ended up with this. Again, I started to give you everything in the conclusions that you need to know, and I'm just giving you more text right now. So sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. So what was previously called severe sepsis is now called sepsis. What was previously called sepsis, that was 2 of 4 SIRS criteria plus suspicion of infection with no organ failure, is now called infection. Because if you have infection and you don't have organ failure, it's important and it's not going to kill you. So when I talk about this and when Dr. Polito and Dr. Holder talk to you about sepsis, we're talking about something which might actually kill you. Previous sepsis is now infection. Previous severe sepsis is now sepsis. Previous septic shock is slightly changed, but is still septic shock. Dysregulated host response, as opposed to a regulated host response. SIRS can easily be a regulated host response. That's a non-septic response. We're looking for something that is badness. Tangible difference of septic shock. What's the difference from septic shock from sepsis? It's a subset of patients, not everybody, a smaller set, with profound circulatory, cellular, metabolic abnormalities, which are associated with a greater risk of mortality. So what's important about that, what's different from previously, is it's not just circulatory. So previous sepsis was all about the inflammation, saying that all that mattered was the inflammation result. Previous septic shock was all about the cardiovascular system. All it was low blood pressure. And it turns out the septic shock is not just intellectually just about low blood pressure. It's actually about low tissue perfusion and the such. And so you're really looking at things in a cellular and metabolic level. So intellectually, that's different. And of course, the difference is mortality. Septic shock is really, really bad sepsis. As I said, going from 10% mortality to 42%, 4 times worse. If it doesn't change your management at all, but at the bedside, if you could tell a family you've got a 1 in 10 chance of dying versus a 1 in 2 chance of dying, that's clearly different. Clinical criteria. Life-threatening organ dysfunction caused by a dysregulated host response to sepsis has 4 elements into that. Number 1 is life-threatening. Number 2 is organ dysfunction. Number 3 is dysregulated host response. Number 4 is infection. Can we measure these? Life-threatening. Yes, as long as we define what we mean. Mortality of X percent, 10%, 40%, 50%, 28-day, 90-day, whatever we define as life-threatening, we can define. Can we measure your organ dysfunction? Absolutely. Can we measure dysregulated host response? Absolutely not. It's an intellectual construct. We can't measure it at all. Infection, can we measure it? Sort of. We can say up front that we are concerned that somebody is infected. We can't actually figure out that somebody's infected until later. It is a retrospective diagnosis, I guess, unless you have pus oozing out of the patient's body. So a concern enough that you send cultures and that you start antibiotics is what we're calling infection. How do we get from the essence of what it is, a definition which has no utility whatsoever at the bedside, to something that we can actually use in the ED, in the wards, and in the ICU? Sepsis bedside definition. Among patients with suspected infection. Suspected infection doesn't change. If you think somebody has suspected infection, that is, you're concerned enough to send cultures and send antibiotics, that hasn't changed. They're suspected infection. If they've got a SOFA score of greater than or equal to 2, or a change from baseline of greater than or equal to 2, they have sepsis. That's it. It's really simple. You suspect infection, they've got a SOFA score of greater than or equal to 2, they have sepsis. Who here knows what's in the SOFA score? Raise your hand. 10% of the room. I applaud the people in the back. But 10% of the room. I'm not going to tell you to memorize this. I don't have it memorized, although I do know the different domains. There are 6 domains if you care. They're P to F ratio, coagulation, platelets, bilirubin, cardiovascular, GCS score, and renal score. But if you can see this and you have it in your handout, look what gets you a score of 2. A P to F of less than 300, a platelet count of less than 100, a bilirubin of 2.1, being on any pressures at all, a GCS of 12, a creatinine of 2.1. It's not hard to get it. Any one of those gives you a SOFA score of 2. So the bottom line is any one of your patients in the ICU, anybody who's a little bit sick, is going to have a SOFA score greater than 2. We don't necessarily think like, oh my God, the bilirubin's 2.1, they're dying. Their platelet count's 98, they're dying. But the bottom line is, if they have any of these things, it gives them, with a suspected infection, it gives them a mortality of greater than 10%. So the bottom line is, if you're concerned that somebody's got infected and they've got any evidence of organ failure whatsoever, they are septic, and it is life-threatening with a higher mortality than a heart attack, a stroke, or trauma. How do we screen for sepsis? Okay, already said that. What we want to say on a screen, we want to take anybody who has suspected infection, and we want to look for who's really sick. So how do we do this? Did this using a database of 7 million patient records, started at the University of Pittsburgh. Dr. Kellum's in the room, thank you. And then validated in multiple databases across the world, public, private, federal, every kind of thing imaginable. How do you identify infection? Exactly as I said. Retrospectively in a database, sending cultures, continuing antibiotics for 3 days, validated in 7 million patient records. Initially looked at what are current existing scales. SIRS, we've already talked about SIRS, LODS, which is something that nobody uses because there's too many things, and qSOFA. So we said, we want to predict badness. What's badness? There's a million things that could look at badness, and we said, what would be something that we would really care about? Dying in the hospital, being in the ICU for more than 2 days. That's clearly badness, right? I think every one of us would agree, if you die, that's bad. If you have an ICU stay of more than 2 days, that's bad. So when we were looking for a screen, we're going to look to see who might do unbelievably bad. And so this is the distribution of current existing criteria. Again, you guys have this slide, but what it's showing you is SIRS is simple, LODS is unbelievably complicated, qSOFA is unbelievably complicated with 1 million different data points. And so we said, can we find an easier way to screen for people who are going to do bad? Die, ICU more than 2 days. We focused on timeliness, ease of use. What we did is looked at 21 different variables, everything that's ever been looked at for saying this could predict badness, and did a multivariable logistic regression analysis for hospital mortality, and that's where qSOFA comes up with. qSOFA, 3 things: no blood tests, respiratory rate greater than 22, altered mental status, systolic blood pressure of less than 100. If you have 2 of 3 of these, your odds of having badness, dying in the hospital, or more than 2 days in the ICU go astronomically up. I told you in advance that qSOFA is good on the floor and in the ED and not good in the ICU. So this is actually looking at comparing qSOFA to SIRS, to LODS, to qSOFA. This is area under the curve. A number of 1 is perfect and a number of 0.5 is basically random chance. So in the ICU, qSOFA and LODS are better than either SIRS or qSOFA. By the way, SIRS stinks in the ICU. And the reason qSOFA is not so good in the ICU is we intubate people so their respiratory rate goes down. How do you measure mental status when we sedate people? So that's why it's not so good. So in the ICU, qSOFA, which is what I had in our definition, is the best way to go. How about outside the ICU? Outside the ICU, qSOFA works every bit as good as qSOFA, every bit as good as LODS, except there's only 3 things. And you'll notice once again what comes in last? SIRS. The things that every one of us is so unbelievable. Oh my God, SIRS is so awesome. SIRS is so awesome. SIRS comes in last in every single way we look at it. In the ICU, outside the ICU. So outside the ICU, qSOFA is a good screen. Inside the ICU, you're looking for organ failure. You're looking for the qSOFA score. I think I have 4 minutes left if I'm looking at the timing right, Dr. Fisher. So I think I'm on time. Septic shock. Again, I've given you the definition for the intellectual construct of septic shock. Circulatory, cellular, metabolic abnormalities with a greater risk of mortality than sepsis alone. Again, intellectual construct, very helpful. We're all clinicians. That doesn't help us at all. We want to know what can we find at the bedside. So once again, we went to database analysis. So this isn't just expert opinion. This is a bunch of people looking at database analysis, starting with a surviving sepsis cohort of 28,000 people, but then being validated in 3 million more charts. And ultimately what we're looking for amongst patients with sepsis, who have a suspicion infection and are already really sick, we're looking for patients with elevated mortality, that is, who's really, really, really sick. A different group, even if you're going to treat them the same, that has prognostic information. Data analysis, what we did is we a priori said what might be important to defining septic shock. We said somebody has to be adequately fluid resuscitated. We did not define that because there's no way that everybody can agree upon what adequate fluid resuscitation is. And we said we would look at hypotension. We said we would look at vasopressor dependence. We said we would look at elevated lactate. We ended up with 6 groups. We immediately got rid of 2 of them. Those are the ones on the right because they made it less than 1%. But ultimately, you end up, therefore, with these groups. Patients who are hypotensive after fluids, patients who are on pressors, patients with an elevated lactate. You can see the prevalence there. And this is how we came up with the clinical definition of which causes the highest mortality. If you are on pressors and you have an elevated lactate greater than 2 after fluid resuscitation, your mortality is 42%. If you're hypotensive and your lactate is not elevated, your mortality is 30%. If your lactate is elevated and you're not on pressors, you have a mortality of 25%. Understanding that 25% and 30% are both different than 10%, 42% is more different. And so when the entire task force came together and talked about these numbers, and by the way, this was not unanimous, but this was a consensus vote, not unanimous, we ended up with the bedside criteria of septic shock being, despite adequate fluid resuscitation, somebody on pressors and an elevated lactate of greater than 2 gives you a mortality of 42%. So for my last data slide, tell me again how I do this. This is the one and only figure in the JAMA paper. So you start with somebody who has a suspected infection. How do we suspect an infection? The exact same way you've always suspected an infection. Fever, white count, something that says, I'm concerned this patient's infected. That's not different. If you're not in the ICU, if you're in the ED or in the wards, you look for qSOFA. If they have 2 qSOFA points, that is a screen. qSOFA does not diagnose sepsis. It screens for sepsis. And that tells you calculate the SOFA score. If the SOFA score is up, they're septic. If you're in the ICU, skip that qSOFA step. If you're in the ICU, you suspect sepsis, calculate the SOFA score. If they have any elevated abnormality, greater than 2, they're septic. If you have somebody who you've now identified sepsis with, then look to see, are they on pressors if their lactate is greater than 2. If they are, they're in septic shock and their mortality is 4 times higher. Because I have 1 minute left before my thank you slide, I'm going to get into the biggest criticism I've heard about this, which is, do we have to wait until somebody has a qSOFA score of 2 to treat them? No. Okay, so all the editorials, and even though this was endorsed by 32 different organizations across the world, every continent with the exception of Antarctica has endorsed this. There are some people who think this is terrible, and there are people who are writing some challenging things in the literature saying, you're going to kill people if you start doing this. If you wait for everybody to have a qSOFA score of 2, like that's kind of a duh, right? If I wait there and I say, I'm going to wait until my patient has a blood pressure of 80 and they've got a respiratory rate of 30 before I treat them, you're going to kill them. That's a true statement. And so don't wait. So if you think somebody has infection, treat them for infection. There's nothing about this that says don't treat for infection. You should treat for infection. If somebody is SIRS positive and you think they're infected, even though that's not the new definition, we could talk about the new and the old definitions and coding and stuff on the CMS on the question and answer. But if you think somebody's an infection, treat them. Do not wait. That does not mean that mortality is going to go higher. But if they have an elevated qSOFA, that tells you the mortality is going to be much, much higher. So do not wait. As before, if you're concerned about sepsis, treat them. If you're concerned about infection, treat them. And with that, thank you.